News, Nairobi.
Well, trust KTN News to keep you updated on the latest around the protest, all to do with the Finance Bill 2024. We'll definitely keep you updated. Well, let's shift focus to Matters Health right now, where the Ministry of Health is set to lead Kenyans in a mass registration exercise for the Social Health Insurance Fund across all the 47 counties. Now, this is in line with the transition from NHIF to SHIF. That is the Social Health Insurance Fund, the new health scheme that comes into effect 1st July 2024, where you'll be expected to contribute 2.75% of your gross salary to the fund that aims to provide holistic healthcare for all Kenyans by expanding coverage and reducing costs. Now, with July just around the corner, we want to briefly interrogate the latest developments arising from that transition from NHIF to SHIF. And I'm now joined by Dr. Timothy Olweni, who's the chairperson of the Social Health Authority, for more details on this all-important transition that touches on the healthcare system in the country. Karibu sana, Daktari.
Thank you very much.
Thank you for your indulgence.
Yes, thanks for inviting me.
I think the best point to start would be the pending registration exercise that is set to be led by the Ministry of Health. When exactly can we expect that to start, and what will be the requirements expected from Kenyans as they turn up to register for this all-important fund?
Okay, first, I think even before I start, I want to correct the aspect of saying transition from NHIF to SHIF.
Yes.
It is not NHIF to SHIF. It is NHIF as a body to Social Health Authority as a body. There are three different funds under this body. There's a primary healthcare fund, the Social Health Insurance Fund, and the Emergency Chronic and Critical Illness Fund. So it is NHIF to those three funds.
Noted.
Or NHIF to the Social Health Authority.
Noted. Well
Good.
noted.
Yes.
Okay. So let's talk about the registration process. Yes.
Well, the registration process, as you are fully aware, I'm sure, we were supposed to commence on the 21st. And the Cabinet Secretary for Health and even Cabinet pronounced themselves on that date. However, you know that the enormity of the task ahead of us dictates that we pay meticulous attention to detail. And I would have preferred to be able to do it right and do it on time. But in the event I'm forced to choose between one of the two, we will do it right. So I want to assure people that despite the fact that we're behind schedule, given the complexity of the project and the multiple teams, there's a lot of teams that are working behind the scenes, doing a lot of work, and I'd like to appreciate all the work that they're doing. However, we're running behind schedule.
Okay. There
are certain field tests that we did in terms of registration. We had a visit to Marsabit because it became important that we don't just test within Nairobi and within a setting in an office or in a boardroom. We went out to the field. There's certain feedback which we got from there, which is now being worked on. We got another field test tomorrow we're going to do in Kajiado. And based on that kind of response, we want to make sure that we go to registration at a point when we are sure that it's going to be seamless. Because you have to remember that registration is just the beginning, but when we start delivering service as well, we're going to start delivering service if it's the 1st of July, if we manage to do it on time. But the key thing is we want to assure people that there's no emergency about it. Service has been continuing under NHIF. If it becomes necessary, that is extended slightly, it'll happen. The key thing is nobody should be denied service on the 1st of July on account of not registering or on account of any of the systems not being ready.
Okay, so the process is ongoing in terms of preparing for the registration process. But in terms of the deductions, they will start 1st July. That is in law, of course, yeah?
Well, the deductions would only start at the new rate if we're delivering the new benefits package. We can't start deductions in the Social Health Insurance Fund and deliver a package that is based on NHIF. So we are going to ensure that the deductions are also going to start at the time the new benefits package is rolled out. That's what the law says.
And I understand that this registration process will be held hand in hand with means testing.
Yes.
Kindly talk to us about this, because it plays a very key component in terms of determining which households can contribute, have that capacity to contribute, and those which can't. So talk to us about that.
Well, means testing came up. The genesis of means testing is because it was realized that the bulk of the funds that were being contributed in NHIF were predominantly coming from those who are on payroll. And that is not by accident, really, because NHIF was originally, when it was conceptualized and when it was commenced, it was actually designed for those in formal employment. However, over time, we have tried to onboard those people in the informal sector because, as you try to push towards universal health coverage, any social health insurance scheme has to get everybody. That's how you get a significant pool. However, it became clear that those who are not in formal employment were not carrying their weight in terms of, it didn't matter what your means were, everybody was paying 500 shillings. That is inequitable to the extent that if you have somebody who earns 5,000 and they contribute 500 shillings, that's 10% of their monthly income. Somebody else earning $1 million, for example, would also contribute 500. So the idea behind that is to be able to let people contribute to the extent that they can and that they should. So then the question came, how do we assess people's income? That's where the means testing instrument comes in. It's also one of the things that is being refined based on the field testing we've done.
Okay.
We want a tool that can estimate your income based on some self-declaration. Of course, it is dependent on the goodwill of the person who is doing the self-declaration. However, it is the best tool we have at the moment. We want to refine it, and for me, especially as chair, as long as we are not unfair to anyone. In fact, if at the moment it might even underestimate your income slightly. But of course, we also don't want to be unfair to everybody and estimate their income above what their means are. So that's the idea behind means testing.
Okay, interesting. So it'll be rolled out as registration is done.
Yes,
as well,
ideally, as you register, if you're in formal employment, then there's no means testing because yours is based on payroll, it's 2.75% of your gross income as declared by your employer. However, if you're somebody who is not formally employed, or I'll use the term, whom your income doesn't come from salaried employment, then we estimate 2.75% of that. As for the law, you're supposed to pay an annual premium.
Okay.
And based on that, you'll be informed that this is the premium you need to pay. So ideally, you should pay it at the time of registration, but by no means later than the commencement of the scheme.
Interesting. Let's talk about the youth bulge in the country and how exactly they'll be catered for. Because we have a certain category, perhaps they might fall under Gen Z, of which they've seen air their grievances around other matters.
Yes.
But when it comes to health, how exactly are the unemployed youth who perhaps have just finished studies and are looking to enter into the job market, whether in the formal or informal job sector, where exactly will they lie? What is their fate?
Yes. In general, for social health insurance, everybody, regardless of age, from the infant or the neonate up to the elderly person, should be covered. Now, the youth are in an interesting place because the youth, at some point, they're still in school, full-time school. At that point, they're covered. You realize, for example, those who go through tertiary education are covered by their parents, and even the NHIF Act itself specified that between the ages of 18 and 25, as long as you're in full-time schooling and not having any income, you can be a beneficiary under your parents' account.
Okay.
However, if you're not employed, then now, beyond 25 years, it doesn't matter, beyond 25 years, you have to be regarded as a single household on your own. The thing is, you're going to be a household, and the question is who pays? I think that's what's most important, because you still need to be covered, because even at 25 years, you get illnesses. In fact, at a certain age group, you're even more prone to accidents, which sometimes are more likely to even give you catastrophic expenditure than anything else. So what we're saying is, either you are going to be paid for by your parents, or if you have a job, then you pay for it. If you're declared as indigent, then this new scheme, as opposed in the past, the government has to pay for you. So all we're saying is that person is going to be covered. The question is who paid. I think the wording of the law in this particular case, because I've seen a lot of this being highlighted, especially on social media, the wording came across as a bit insensitive. But I want to assure people that in principle, all we're saying is everybody needs to be covered. The question is who pays.
Okay, and we'll definitely have more time for civic education because it needs to be broken down in a way that the masses understand. Let's just briefly talk about these 3 new funds that are set to cover various levels of healthcare. You mentioned them, but talk to us briefly about the benefit packages that are available to members of the public under SHIF. Yeah.
Even before I go into that, the reason why these funds were separated in the manner that they are is that it was realized, for example, we were concentrating too much on curative care, which stands right in the middle of where we need this continuum of care. So prevention and promotion, first of all, as teaching time saves 9 applies even in medicine and in healthcare. So we wanted preventive and promotive care to be funded. In addition to that, you've got curative care as it is, and you want the entire spectrum of continuum of care to be provided, whether it's outpatient care, inpatient care, whether you access it as accident and emergency, and whether you go into critical care. Then you've also got end-of-life care. So that entire spectrum. How do you fund it? Primary care is the Primary Healthcare Fund. This now is funded by the Exchequer. Everybody's entitled to it. It's the government that is funding it. All you need to do is be a Kenyan citizen and someone who's registered.
Okay.
Then you've got the curative section, which I've talked about. There we've got a benefits package which has also been expanded and enhanced. But there again, you access care, but there you have to be a paid-up contributor.
Okay.
Hopefully everybody will be a contributor. So it shouldn't be an issue that some people have got it, others don't. Because it's for the first time we've got government paying for those who are indigent. We have got everybody in formal employment paying, and even those in informal employment after having needs testing.
Yeah.
And then the Emergency Chronic and Critical Illness Fund is there to be able to take care of those situations where there are medical emergencies, and that has been a problem in terms of who pays for medical emergencies when people show up with conditions that are of an urgent nature and that can cause deterioration of their health and their livelihood. So emergency care, again, that is funded by the Exchequer, and you're entitled to it regardless of whether you're a paid-up member or not.
Okay.
Then there's a chronic and critical illness fund, which is for paying for those who have exhausted their benefits under the Social Health Insurance Fund. So for example, equivalent of NHIF before, we had people who are exhausting their benefits. So those who've got critical illness, those who've got chronic illness are going to be paid for from that fund. So it's an issue of different wallets, but what we want is a continuum of care across the entire spectrum.
Okay, well noted. And perhaps as we finalize, due to interest of time, but what's the way forward for any person, any individual who might have made advanced payments to NHIF at the point where transition will start? So when the Social Health Authority comes into place and you've already made advance payments to NHIF, are they simply transferred? Is it a cause of concern? Talk to us.
Yeah, this has been a matter of concern. Again, I'd like to assure people that on the 22nd of November, when the Social Health Insurance Act came into being, all assets and liabilities and obligations and so on, etc., became transferred to the Social Health Authority.
Okay.
So, for example, in this case, an advance payment of a premium is a liability on the part of NHIF and Social Health Authority. So all that will happen is once your new premium has been determined, that advance payment will be factored in, it will be prorated in, and you'll be told you're going to pay whatever premium you're supposed to pay net of what you had paid in advance.
Okay, and perhaps a general question as we finalize, because there might have been inadequacies or gaps within NHIF and the whole healthcare value chain system that have been highlighted, and we're seeking to fill those gaps through the Social Health Authority. What are some of these gaps that are critical and that you think will be addressed through the Social Health Authority?
First, I think is the comprehensive nature of the care. There are a lot of new benefits that have been introduced that didn't exist.
Okay.
And I've also seen sometimes it being highlighted in social media that some of the benefits that have been introduced are not sufficient, or don't go far enough. However, people don't highlight the fact that this didn't exist before. So this is a new change, and you have to realize, especially when you introduce a new benefit, for example, oral health services or dental care.
Yeah.
It wasn't there before, so we don't have any utilization data. You have to be very cautious about how you introduce it so that you don't overstep whatever your budget is. So we're introducing it in a modest manner, and then after looking at utilization, it will be improved. But I'll give you examples. I've talked about the primary care, which was not funded before.
Okay.
I've talked about the dental services. We have got palliative care services. We've got end-of-life care, especially mortuary services, also being paid for. So there are many benefits that have been introduced which didn't exist before in this new package.
Okay, and unfortunately, so much to talk about, so little time. But
Yes.
Good thing is we've created a partnership with the Social Health Authority that very soon, especially this week, we'll be having a conversation on an array of issues touching on the healthcare sector. So this is simply an appetizer, quote unquote, in terms of more information coming your way back at home in terms of what you need to know when it comes to the transition from NHIF to SHA, as he mentioned.
Correct.
Thank you so much, Daktari Timothy Olweni. He's the chairman